unfortunately, these are very nonspecific symptoms. Shortness of breath and cough have a lot of causes. And if somebody has a history of smoking, it's easy to attribute it to COPD, which is very common, or asthma, or heart disease. And by the time people see me, almost all of them have had full cardiac workups, but they haven't had a CT scan yet of the chest or lung function testing that could have pointed them down the road that they're dealing with lung rather than heart disease.
Patients often present with very vague symptoms for pulmonary fibrosis. In primary care, our visits are often very rushed. Patients may come in with a dozen different diagnoses. Half of my patients will present with the same symptoms that many of these patients present with: shortness of breath, occasional cough, sleeping issues, fatigue. Many times the patients don't even necessarily think it's something important. So these vague symptoms often make it really tough to try and nail down what the problem is.
The primary care provider has a plight. Incredibly busy, non-specific symptoms showing up in an office with patients in the waiting room, and very little time to make these diagnoses.
Oftentimes, we see as a large tertiary referral center patients who are coming to us 2-3 years after they've been diagnosed or after their symptoms started, and there's this huge gap from the time of their symptoms to us diagnosing or treating patients with the appropriate therapies.
As a primary care doc, a lot of what I do, frankly, is trying to eliminate things that are going to kill people within the next week, and then we work down from there. So if many of us have that opinion that if it's a problem that can wait to be diagnosed, we have to eliminate the initial things first.
This initiative really excited me. It addressed what I think has been a long-term passion of mine, that while we're very excited in the pulmonary fibrosis world about all the advances we're making with therapies, the ability to slow progression of disease, lots of active research, and while we've been really excited and because we've made so many advances, we've sort of missed an opportunity to include our primary care colleagues in our excitement and our advances, and to really engage them in the process of finding pulmonary fibrosis so that we can treat it.
We know from our specialty that by the time a patient comes to a pulmonologist, they've been having symptoms for 3, 4, or more years. We see them incredibly late, and during that time, they really have not received the treatments that are already approved, or access to newer treatments, or the whole comprehensive approach. So we really believe that by earlier diagnosis, we can change the course of how patients deal and cope with pulmonary fibrosis.
Figuring this out early so that we can begin to develop a management plan together with our primary care colleagues in a timely manner is really the key in sort of what we really want to be doing when we're managing these patients. So this initiative, we want to be very practical, easy to access, and change-provoking, so that a primary care physician has very simple tools at their hands to remember quickly that this could be pulmonary fibrosis. Simple tools as, here's how to listen to a patient's chest and hear crackles. Here's a questionnaire that you can use quickly to say, oh, this might be an interstitial lung disease, and other forms of diagnostic tools that we use.
PCPs can utilize this toolkit in a lot of different ways. The first way is just obviously through education. What this is designed to do is to add to our own arsenal of how we can actually improve treatment for patients. Most of us as primary care docs have seen through the years that our time with patients is cut very short. We have multiple complex problems that we have to deal with, and many times somebody with very, very vague symptoms like this can get lost in the shuffle. This is designed to aid us in understanding the direction where diagnosis and treatment of this disease is going. We can make huge differences for our patients by getting them to our fellow specialists and then working with them to help these patients in the long run.
I think by bringing together primary care and specialty medicine, and especially pulmonary medicine, we really hope to build a team that gets to patients earlier. And treatment really goes beyond the antifibrotics. Yes, those are important, but the comprehensive services that we can also offer that really will matter in the lives of these patients, improve the quality of life, and we hope actually improve the outcomes for these folks as well.
By bringing together primary care and pulmonary to understand, first of all, the gaps on why this is happening, and then from there learn about tools that we could utilize or create to improve the time to diagnosis for patients with pulmonary fibrosis.
By bringing together pulmonary and primary care physicians, I think we can make a better life for our patients. And again, my experiences even within this subcommittee working with pulmonologists, I've learned a lot about interstitial lung disease that as a long-standing family physician I wasn't aware of. And so I think it's made an impact even on my own patients and my own practice. And I'm hoping that we can do the same for my fellow primary care docs.